Hi, everybody. This is Erica Mello and Susan Clinton, and welcome to episode number 109. I keep saying that with emphasis because can't believe it's not been 109 episodes, right?
It's crazy,
Um,
right?
I know time definitely literally does go by so quickly. And I'm happy to be here with you today. A couple things before we sort of dive into the podcast and the intro. We are hard at work on our podcast membership, and we are literally almost about ready to launch it. And we'll give you all the details in the next episode. And we are going to have a great podcast club, and there's going to be a monthly or an annual membership, and you're going to get this podcast, obviously as usual, and then we're going to have two other special podcasts. One is Ask Me Anything sort of, or Ask Us Anything Q&A, that we'll release once a month, and one is just another special podcast that of master clinicians doing great things in our field, treating difficult patients. Right, Susan, do you want to elaborate more on that?
Yeah, we were planning on doing some fun interviews with people who are interfacing with different systems with complex patients, much like what we're doing, and just really getting a feel for the vestibular system. How does that affect, pain and, drivers and different things that we're working with our clients, and all other systems as well. And we'll be talking to different, like Erica said, master clinicians who are going to sit down and generously share their time and teach us a little bit about what's going on as well. So we're happy to bring that to you in this new podcast club.
Yeah, and there are a lot of great clinicians in our field who fly under the radar, so to speak, right? And I firmly believe that it's important that we talk about people who are doing great things in our field and treating complex patients as well. So look forward to that. We're going to have also really some great show notes as well as other resources and videos dropped into the membership. So just look for that, and we'll give you all the details. This particular patient I've been treating for a long time, and this is going to be a part one, part two. We're sort of getting into these part one, part twos because I think they're good, and I think it gives everybody a chance to reflect on what has been discussed in the initial in part one. And this patient I had been treating for quite some time, many years ago, and he sort of got better and came back recently for multiple issues. And this really we talk about trying to make a hypothesis based on his subjective or his narrative, and then a little bit I'll talk a little bit about exercise progression, but the thrust is especially in part two, we'll be really focusing on the exercise progression for a patient like this. So in this episode, it'll be like the intro to him and what I think the driver is, and a little bit of treatment, and I want to just put some sort of thoughts in your head before you listen to part two. So we hope you enjoy the episode. Hi, everybody. This is Erica Mello and Susan Clinton, and welcome to podcast episode number 109. Here we are.
Here we are. I'm good. Here we are. Podcast number 109. Looking forward to it.
Yes, indeed. We're going to get right to it, guys. So as you heard in the intro, this is a patient of mine, and this will be part one, part two. I do like these part one, part two. So it's important that you actually listen to the first part before you listen to the second part. So I'm going to be a little bit, because we are doing this in two parts, I'm going to be a little bit specific in terms of his subjective, and maybe as you're listening, Susan, and as the listeners listen to the podcast, think about maybe what could possibly be this guy's driver or drivers, and how you would go about proving that or disproving that, get your hypothesis. So he is a 34-year-old male here in New York City, and I've seen him before, prior to COVID, actually many years ago. I think probably the last time I saw him before now is 2016, maybe. It's been a while, even before that. Don't you love when patients who you've seen years ago come back, right? So, I don't have a problem with that, because this is another subject for another podcast. But your patients are your patients for life, whether you want to have a relationship with them. You obviously don't want them coming back every 5 days for the same thing, so to speak. But it's been a while. So he came in and I had sent him the paperwork beforehand, like CSI, DAS, and all that. He was pretty okay on all that, not anything that would, be catastrophizing, things like that. So, and I know him as well. He's a good coper. So I'm going to just talk about the body regions and what he told me. So he actually wanted to start running again. That was like a major goal of his. Now it's like he's running and he's okay. But that was sort of the first thing he said to me. And in terms of like his symptomatic areas, he had multiple. All right. He had right foot gripping. He had right anterior lateral hip pain. And he pointed right at his sternum, like pain, like right through to the sternum. And then imagine you're just putting like a line from the sternum into the thorax. So then he pointed to his back, like T6, T5, T6, T7. And then he had bilateral neck pain, anterior and posterior. So we have right foot, right hip, sternal AP, and then both neck, anterior, posterior neck. His main, I would say, important issues were the foot and the hip. But as you know, they're all related. So you're thinking, well, I'm not going to treat 1, 2, 3, 4, 5, 6, 7 body regions. That's not happening, right? So when you see something like that, you're like, well, this is what I say. I think there's probably at least 2 areas that need to get looked at. So that's what he came into.
Did he have a priority when he came in? Or does he just open, like, here it is, I want to run again, but these are all my issues? Or did he say, my hip is killing me and I want to run again?
No, he didn't say my hip is killing me.
Okay.
No. So I had given him, when I saw him years ago, he had a foot issue and I had given him things to do. And so he said that, and some hip stuff. And so he had said that, and I'm going to go that into a second, that work was helpful, over these many years since prior. So he also said to me, that he plays the piano and the guitar. Looking back at the notes now, I don't think he plays as much currently, but that was in his history just for various reasons. And then he also said something that was interesting to me as I was looking over my notes this morning, that he was twitching less. And I'm like, twitching? Where did that come from? So I've not seen it in person. He doesn't complain about it anymore. But I wrote that in the eval in the first section. So he had told me that in terms of activities, his biking was pretty good and it was a lot better. So, because sitting is not a problem for him. He said none of this really bothers him with sitting. It's mostly standing and then sort of moving from standing. So it's really standing. And he told me that he used to ski, but that bothered him in all the areas. So he does snowboarding now and he's okay. And so you think about listeners, well, what's the difference? There's a big difference between skiing and snowboarding, right? So, and then he also said to me that I must have given him cat camel over the years. So that lying all fours, cat camel, that helped him as well. And then he also told me that this is the words he used, trying not to do a posterior tilt was helpful.
Okay.
And I'm like, interesting. So then he went to the foot. He said, when I released, I must have given him his self-release years ago in 2016, like for an anterior tibialis. He's like, I released my anterior tibialis. My foot feels so much better. And that, but it doesn't really do a lot of things for my hip. It actually kind of makes it worse. But then when I work on my hip feels better. And then my foot doesn't feel great now. But he goes, when I work on them at the same time, I'm okay. And I'm like, I must have taught him well because over the years, but that's what he did. He didn't mention like the neck or any of the other stuff. It was really mostly the foot and the hip. And so I'm just trying to think of anything else that he told me in terms of, his past medical history. He has some digestive issues and quote unquote, heartburn is what he said, basically. Sleeping is no problem. The best position really was lying on his back. He does have a secondary knee issue, which actually comes into play as I will discuss. Any questions, Susan, after any of that?
So is he still having the digestive issues and the heartburn?
Less so, less so.
Because that's making me think about his sternal pain.
Yeah, exactly.
That one might be a visceral driver.
Yes, agreed.
Yeah, it's not unusual. And then maybe even a little bit of that front of the neck thing. So
Yes,
yeah, so
yes,
that's why he likes to sleep on his back if he
yeah,
has heartburn too, because he can probably elevate his head up a bit and it feels better.
right, right.
Interesting, interesting.
Yeah,
And
yeah.
digestive
Uh,
issues. So, and
Other than that,
it sounds like this guy is trying not to be a butt clincher. He's trying to
right.
move himself out of posterior tilt, so he's trying not to be a butt clincher. Okay, okay.
I thought that was interesting because
Mm-hmm.
he said try not to posterior tilt was very helpful. Cat camel was very helpful, and I'm like, interesting. It sort of gets him in a different context. But the
Yeah,
snowboarding, the skiing, he, now I mean now I know what his drivers are, but skiing, he's got his feet clipped in. I'm not clipped in boots, and then snowboarding, you're more in this sort of stride stance, and so you think about it, just for listeners, skiing are very rigid, right? You've got one ski, two skis, and you've got the boots, and you have to move in and out of certain patterns, but you've got the boots that are limiting you, right? In snowboarding, the boots aren't as rigid, and you're in a more of a stride stance, and you can move around a little bit easier versus skiing. So he
yeah.
actually now snowboards. He
Well, and
does not ski.
snowboarding makes you bend skiing makes you bend your knees too, but snowboarding,
Yeah,
you have to keep your knees bent because you'll fall over. And so that
right.
takes him into a different pelvic position, which
Mm-hmm.
may not be as it's just a different movement pattern that doesn't trigger off the pain response.
Right, right,
So,
exactly.
mhm.
Yeah, and so and biking is fine. So running was like kind of the goal. You know how people, like, I always ask, is there something that you want to be able to do that you're not doing now? And he said, well,
Mhm.
I'd like to run. So and he didn't really have a problem playing the piano or the guitar, and I'm sure he fell into some movement pattern, but he doesn't really do much of that now. But that was in his history. So, and bear in mind, I know him from a prior treatment. So, no history of concussion, no sort of, men's health issues. He just had mostly digestive. And in the pandemic, he has been working from home a lot, but generally a sedentary financial profession. Okay. So it's not like he, stood a lot. He basically sat. He was just sitting in a different environment. So what I thought was interesting, and I'll just say again, is that he was trying to treat himself by the tools I gave him some years ago. And he was releasing the anterior tibialis with the ball, or I don't remember what I gave him in 2016, but it was obviously helping him. Okay. Because his foot felt
Mhm.
very grippy. It was obviously giving him the ability to fan, to absorb the ground reaction force better on the floor. And then with his hip, he felt that he was, whenever he released his foot, though, his hip would sort of be not happy. So he found that when he did them together on the same day, it was better versus doing them separately. So I'm thinking in my brain, well, they're obviously making each other worse when you
Mhm.
do them, right? And so that's radars in my head. So I'll just take you to, so since standing was very meaningful for him, and that's basically what his problem was. And he did,
Mhm.
and I wanted to screen other issues, but I'll tell you what I did in standing, because that was sort of the meaningful movement for him. And then I looked at other things because he wanted to be able to run, and running is one-legged, right? So,
Mhm.
so when I took a look at him in standing, I'm just making sure I didn't forget anything here. Okay, in standing, the center of mass was on his right leg. And then bear in mind, his right side was the right foot, the right hip. Everything else, sternal and neck was sort of central or bilateral, right?
Mhm.
And I was thinking, well, I've had a few patients lately where their symptomatic side, they're actually standing on that side. Usually they offload that side, but he was one of these people that stands on his symptomatic side. And it's interesting now that I'm saying this, the people who tend to do that have more of a global movement pattern problem. At least that's my thing. I'll talk about this later. I don't want to spill the beans on him. That's what I think. So, but I was like, well, something's taking him to the right. Obviously, something's taking him to the right. And that could be why he's the problem in standing. So in standing, his right foot was extremely rigid. He literally, when you have standing, you can see that person's that there's no sort of crease in the talocrural joint. He's got like no sort of standing dorsiflexion. There's no real fullness in the talus, in that sort of crease there. He's got his feet are gripping, just sort of a grippy, and he complained about that. His right hip was in sort of, I didn't want to, I'll use Shirley Sarman's word, like really anterior femoral head. He's sort of, he's not in like any kind of extension, but he's gripping his right foot and he's sort of pushing. He's standing with like I'm demoing this on the Zoom, but he's sitting with that right hip sort of forward, then more left, like a rotation to the left, in a pelvic rotation to the left, which he had. So right foot gripping, right anterior femoral head, pelvis just follows it all up and goes right to the left, right? So that I would have expected to see based on just his foot.
So was his thorax following the pelvis, or was it rotating opposite?
It was going the opposite. So what I saw was a couple.
Was was the thorax and the head in midline and the rest of the body off to the right?
Yeah. So the head was midline in standing. The thorax was to the left in standing.
And the
so translated left, rotated right.
Okay. Yeah.
Yeah. So counter twist. Yeah. The pelvis was to the left. So the right foot was gripping, right femoral head anterior, pelvis to the left, thorax to the right.
Yeah.
So it was just
and head and midline.
Centered. Yeah.
Okay. That's interesting.
Yeah.
Especially with the sternal T5, T7 kind of ish. Pain.
So why do you say that? I'm curious.
Well, I'm just wondering if that's the counter twist is setting up a tension pattern there, or is the heartburn and digestive issues setting up a tension issue there that pulled him off to the right? I don't know.
Right. Yeah. Exactly. Exactly. So, I'll just basically I put my hands on his thorax and I do a general sort of pass through, and he had a lot. He had a lot of sort of left thoracic translation, and he sort of was compressed on his right side. So it makes sense, given what we saw below, but a lot of compression, and my bias, right? And then I sort of went up to the neck and he was pretty centered. He didn't really have, even though he had this bilateral upper traps and neck flexors pain, his head was fairly centered. I didn't see anything crazy in his neck. In standing, what I sometimes will do is, because the neck is not meaningful, and it's meaningful, but it's not like I have a priority list that I look at, right? And so the foot's on the priority list, the hip is on the priority list, the thorax is on the priority list for him, because those are meaningful. The neck he mentioned, but I just had him in standing, just turn his head to the right, turn his head to the left, just to get a baseline. I noted the percentage of range of motion. That's all I did. And so I actually did try to get him. I said, can you get onto your right leg a little bit? I mean, onto your left side a little bit. And he couldn't figure out how to do that. You know how patients are like, well, try, and we do that, right? So I just didn't. I took pictures. So I do the pictures, the normal, narrow, wide standing. And it was interesting with his narrow standing, he looked a little bit worse, but not horrible. And in wide, he looked much better, right? So, but nothing crazy from that perspective. So I did have him do a one-legged stand. I just baseline. So head rotation, right, left, limited, but not symptomatic, nothing crazy. One-legged standing. Okay. I said, do a teeny one-legged squat. When I tell you, Susan, this guy was all over the place. Okay, all over the place. And so when he went into a right one-legged squat, so his left was okay. And I mean okay in air quotes, like it was a functional, right? When he went onto his right leg, he went down, and his thorax, right, left, everything was all over the place. When he straightened his knee out, his whole pelvis went to the left. I mean, we're talking he went over on the right outside border of his right foot. And I mean, he had to hold on to the table. So I just noted that down.
Mm-hmm.
Okay. Then I had him do, I'm just looking at my notes. Then I had him just do a squat. I said, just do a basic squat. I wasn't going in and assessing a ton of movement here. I was just globally watching right now because standing was the meaningful for him. And so
Yeah.
I'll tell you what I did in standing, but I just wanted to do these other tasks as baselines or barometers. Took a look at a squat, same thing. Every single squat going down was fine. It was bilateral. He did center himself when he went into a squat. I was like, that makes sense. He sits okay, he squats okay, he centers himself. Something
Yeah.
hits, it's
Snowboards.
bilateral.
Mm-hmm.
Yeah, exactly. So
And
he was
snowboarding
squatting.
isn't one-legged.
Right, exactly. So when he
Mm-hmm.
went from a squat to a stand, he couldn't straighten his right leg out. He had to once again get over on the outside border of the right foot and like literally shift his pelvis. Really? So I said, can you go on the wall? I go on the wall. Put his hands on the wall. And I feet, normal hips width. I said, can you just squat for me? Squat down. He did fine. I said, can you go slowly back up? And I prevented the pelvis from moving. I was like, I just don't, I don't want you to shift your weight over. I'm just going to keep your pelvis from doing this funky thing is what I said. He's like, okay. So he squats down, he comes back up. He cannot straighten his knee out. So I'm holding the pelvis and he couldn't straighten it out. And I was like, I took my shoes off. I put my foot on top of his foot so he couldn't like go into that sort of rigid posture, supinated posture in the foot. And he literally couldn't straighten out, Susan. And I was like, and so that
Wow.
became like, he's like, oh, wow. Like he didn't realize it
Mm-hmm.
because he compensates. And I said,
Yeah.
look, you compensate well and you're good, but
Mm-hmm.
but when I block some movement or sort of take your compensations away, the reality unfolds. You've got some reason why in your system you're not straightening your knee out. And his knee wasn't, he didn't have any knee problems. I mean, he didn't come and say, Erica, my right knee hurts. It wasn't even
Right.
on the radar.
Mm-hmm.
So in a freestanding squat, he looked, he functioned okay. He compensated, he straightened his knee, he turned his pelvis. But when he was in close chain on the wall, it took out a lot of his strategy. There you go. He couldn't do it. So love your thoughts on that.
Yeah,
Any
that
thoughts or yeah.
so it's interesting to me listening to this. Well, first of all, I got, the thoracic twist in there, kind of has me thinking a little bit along that line. But back to this part, it's, all the activities he does are activities where he can be somewhat centered, but biking doesn't bother him because he doesn't have to straighten his knee. So he's not he's not twisting off the bike. Snowboarding, he never really probably has to straighten his knee so he can move back and forth. Sitting, he's okay. It's when he stands up that he has a problem. And, and then the knee going into extension sounds like it's an issue. Now, this is the thing is that you could have a different movement pattern at one joint that can affect the joints above and below. And they can all, in that closed kinetic chain, they can all feed in and out of each other. So is the straight knee what's driving the foot over to the side into supination? Is the straight knee what's driving the femur anteriorly? That's making the pelvis tilt backwards into, kind of his normal little butt clenching.
Yep.
Which is I think very interesting. So it's like you have a silent driver. You have a driver that's non-painful somewhere in there. And is it really the driver? Is it being driven by something else? But, I just find it very, very interesting when you didn't allow his foot to move, he couldn't move the other joint. So, which is very, very interesting to me.
Yeah. And I always tell patients, excuse me, that, we could be treating an area of your body that's not painful, but it's dysfunctional and could be driving your foot pain or whatever, down the road many years from now. So this was something he's had for a long time, but he's managed well. And the reason why he came back is that he just ran out of options for self-treatment, Okay. So I also took a look at him in lunging, and he was generally okay with that. Not surprising. He snowboards. Lunging was okay. His back foot was a little funky, but it was nothing like the closed kinetic chain wall squat and the regular squat and the one-legged squat. right?
Mhm.
So, for him, I just noted that, and I didn't want to go down a rabbit hole with him because, you know, because I can, because because he's
Mhm.
that kind of patient that he's so motivated, he's so compliant, he's so interested in the problem solving nature of what I do or what we do that I was like, don't digress here. So for the listeners, I just think about the information that you have so far, multiple regions of the body that bother him, you know, releasing his anterior tibialis at home helped him, did not help the hip, and vice versa. Working on his hip did not help his knee. Excuse me, it did not help his foot. He also, snowboarding and skiing, the difference between that, sitting is fine. So, and standing bothers him. Cat camel, very helpful. So just think about that alone and what you possibly think the differences are and the regions of the body that are stressed with skiing versus snowboarding, right? And as Susan mentioned, snowboarding, you have to keep your knees bent, right? So skiing too to a degree, but with skiing, you're much more rigid in your feet there. Whereas in snowboarding, you can do a little bit more and you've got more side to side movement, right? Whereas
Mhm.
skiing, you're more up, your side to side comes from more and more of your trunk. So just think about, listeners, what potentially that would be driving his symptoms, or why would one be better than the other for his body. Um, okay, so what I did in standing, I'm going to go back to standing because that was meaningful. So you think about, he was on his right side. Generally, in other people, I'm like, well, if he's on his right side, it could be something in his left foot, which I will tell you was not the issue with him. So what I ended up doing, because he gave me that's such a great history, I ended up in standing, just well, for the purposes of the podcast, just modifying the foot. I just had him lift his right heel up. I did a little distraction on the rear foot, put it in a quote unquote better position. I'm just going to leave it at that. And basically, I had him stand. And what we ended up doing was, I checked his head rotation. I had him just do a little bit of one-legged standing, just to see what that foot sort of modification did to his I don't even want to say his symptoms, because he really wasn't getting symptoms when I saw him like in the office, just what it did to his movement pattern. So I think it's important that we try not to focus on the symptoms. I know it's hard, but we're movement specialists. And so you may not be able to reproduce the patient's symptoms in the office. So see what it does to his global movement patterning. So I modified his foot, his head rotation got a bit better. His left was not really good. I mean, it was the same, no change there.
Mhm.
And ironically, you're going to laugh with this because you know my bias. His entire thorax got much better.
Mhm.
I was like, okay. I mean, all of them. He did have a right shoulder, I don't want to call it thing, but it was, in standing, it was a little bit sort of hiked up, but more of a
Mhm.
postural issue. And I noticed he's like, oh, Erica, my right shoulder feels better. And I'm like, you have a shoulder problem? He's like, no, it just feels better when you're doing this, right?
It
So his
feels
all of
different. Yeah, he's in tune
exactly,
to himself and he knows when he has a change, which is
yes,
awesome.
which is why I love treating him. So he's
Mhm.
like, my shoulder feels better. And then, all of his thorax significantly better, not 100%, but better. What did not look good was his neck rotation to the left, and his hip was worse. His hip was worse.
Okay.
So I took away the compensation at the foot, and then the hip was like, oh, no bueno, and I'm going to make it even worse. And that's what happened, which is consistent with his story, saying that when he
Yeah.
released his anterior tibialis, it made his foot worse. That's what I want the listeners to think
His hip
about,
works.
right?
Yeah. Yeah.
Yeah, made his hip worse. And
Mhm.
so he's like, oh, I wonder what because I can go down a rabbit hole with these people, right? And that's my bias. So um, he's like, well, I wonder if you did that to my left foot. I'm like, I said to the patient, I was like, that'll make it probably, I don't think that's going to be the right thing to do. He's like, oh, can you try it? And I knew that would take me 1 minute. So I did. I did the same thing to the left foot that I did to the right foot. You want to know what happened there? Take a guess. Take a guess. Everything was worse. Head couldn't
Yeah.
move. It was way worse way worse.
And he's already, doing all that crazy stuff on the right side anyway.
Yes, yes. And so I was like, does that answer your question? He's like, oh yeah, yeah. Like he couldn't feel it. His head was like 50% worse in terms of range of motion, right? His hip was still forward and everything, and the thorax was all over the place. And so there's no way in hell I would ever treat that left foot ever. I mean, maybe I can't say never, but until he had a more robust system. But left foot was not on his radar. I was not even going to look at it. And he asked me, and I knew it would take me a minute.
Yeah.
Okay. And I wanted to prove to him that that it was not going to be an option for treatment. So I'm going to move on from there. So what I did next is I modified his right hip. All right. And so what I did was, and all I did was just like go back. I'm on his sort of sit bone, and I don't want to go into the nitty gritty of this, but however you want to make the hip sort of, I know Shirley Sarman doesn't do a ton of, like, she talks about it, but I literally just picked up a sit bone, gave him a little bit more space in the front of his femur, and that was that. And then I just had him, I had him turn his head, I had him squat. I wanted to have him squat because in standing, it was sort of hard to see a little bit about what the foot did in terms of when the fanning. So when he squats, the foot fans, and then when he comes up, it folds. I wanted to see what happened to the knee with that. Okay. So when I did correct the right foot he was able to squat, but coming up was still not great. Okay. So, but that was another screening test I looked at. And I don't want to confuse the listeners. Okay. So it was really standing. So when I did modify the right hip, everything was like still good. The thorax was good. His pelvic rotation improved. But his right foot didn't really do anything. It was not like, so I had him go up on his toes a little bit. I had him go up on his toes a little bit. Sorry if you're listening. If listeners hear the fire truck, sorry. I had him go up on his toes a little bit, and he was pretty okay with that. And so when I was correcting his hip, and I went down into a squat, he still, he was really getting that sort of rigidity in the right foot, and he was really going off on the outside border of his foot. So I knew that the foot and the hip didn't do good things to each other, but I was like, what if I try to, combine the two, do the two sort of modifications together? And I will tell you what I did. I actually ended up, because his neck rotation really wasn't improving, and it wasn't really meaningful for him, I just said, I've talked about this before. I just went in and gave him a little distraction to his head, and I had him squat and stand on the leg and looked at him in standing, and it didn't really do a lot. I mean, I think it maybe made other things a little bit better, but it wasn't this feels much better. So that was sort of the priority list. And so what I ended up doing is I ended up doing both together. So I had him stand, just basic standing. I modified, corrected his right foot, and then I did the same thing with the hip. Okay, I just picked up a sit bone, and then I had him turn his head. I had him squat. I had him, I actually had him go against the wall. So in standing, freestanding, his head rotation was much better. His squat looked better. He could come up into standing a lot better. So when I put him on the wall, and then I did the same thing, I modified the foot, modified the hip, put him on the wall. He went down and was squat. He was fine. He went up into tried to straighten the knee out. He could do it, but I was really trying. I had a really difficult time holding those positions. He was really fighting me. And then I took him off the wall, and then I did the freestanding again, corrected the hip, modified the foot. And then I had him do his head rotation, thorax, everything looked good. I had him lift his arms up just to see if anything was harder. So for the listeners, if you want an idea of what it's for the rest of the body, like if you're doing something down at the foot and on your hands and knees and you can't really put your hands up or see, just have them do a movement, have them lift their arms, turn their head. If something was way worse, then you obviously made something worse up above, whether it's neural tension or the head, whatever, you made something worse above. So with him, when I did both together, I did not make, but it was really hard for me to do the both together. I'm going to stop there And that may have been sounded a bit confusing, but I just want to make sure that people know I actually ended up having to do both together, because doing them separately was making his nervous system didn't like it, right? Something he just didn't like to be lengthened, right? So I'll let you go ahead, Susan.
Yeah, so I just want to clarify on what you did on the pelvis was you actually put you just went underneath his sit bone and just basically rocked his pelvis a little anterior so that you actually you actually brought the acetabulum over the top of the femur a little bit. So the femur was nestled into the acetabulum better. Is
Correct.
That what I'm hearing? Yeah.
Yes.
Okay.
So I grabbed the sit bone and scooped it.
Yeah. So that just
posterior and superior.
Yeah. And so basically what that does is that brings the acetabulum over the femoral head, because the femoral head was rotated anterior in relationship to the acetabulum. Okay.
Correct. And so when I did the two together, that was much better, but it's consistent with his history. Working on the hip makes him worse, makes the foot worse, and vice versa, which I confirmed in standing. But I wanted to see, because his foot, when I did sort of correct his right foot, a lot of things were better, except that the hip was not. Okay. So the hip is in his meaning, right? So if I just worked on his right foot, his hip would not really go anywhere to make it worse. So it brings me to the point where you need to sort of work on the two together. But the relationship at the beginning of the treatment, the first visit, the relationship between these two regions of the body is that they make each other worse. So from a neural tension perspective, I would, for the listeners, just think about that. Why would that be? I've been treating him now, so I kind of have an idea. Do you want to have any thoughts on that, Susan, or do you want me to keep moving?
No, I don't want to have a thought on it yet, because I feel like I need a little more data.
Okay.
So I have a couple of thoughts, but I still want to, he said that when he does one thing with one part, it makes the other part worse. When he does one thing with the other part, it makes the other part worse. So it makes sense to do them together. And whether or not it's positional, neural tension, dural, not sure.
Right.
But he's definitely got a system that's pretty, nociplastic. I mean, not nociplastic, but neuroplastic. So he can change. My thought is still kind of hanging out is like, why isn't he having such a hard time moving when you get the ankle and the hip in a little bit more of an optimal position for movement?
And there's no trauma there.
Yeah, and it doesn't really have to have trauma. It could, I just. Like, what's the movement pattern? Why is the movement pattern bothering that? So that when he actually gets a foot or his hip into an optimal pattern, is it take him so far out of his stored movement pattern that he can't function everywhere else? That's kind of the interesting thing. Or is it something that just needs to be trained in because it hasn't worked that way in forever?
Right.
So
probably a little bit of the latter too.
Yeah.
So if you think about the direct connections between the foot and the hip, there are direct connections, right? I mean, you've got muscular connections, you've got neural connections.
Yep.
So I always, and people, and so he just said, releasing these muscles make you feel better. And I was like, well, and I said to him, what about getting some neural mobility? And I explained that to him, right? So on the first session, so I evaluated him and I did do a little bit of treatment. So I went in and I assessed the foot. Okay, there's a couple things I did. I went in and I had him in sitting, and I mean, his literally, and I'm gonna say like zero dorsiflexion, like even like minus like 15 to 20. I mean, a lot, like zero, like I'm talking zero, but like negative, way negative. And do I have a goniometer? Did I measure it? No. But
well, that was going to be my other thought, is that, okay, so we've got this going. If there's lack of range of motion in the ankle, that could be driving the hip. I mean, that could be driving, well, the hip and the knee, but is it the inferior or superior tib fib joint or both that are just not moving optimally either?
Right.
But they're just not symptomatic,
Exactly.
So his eyes aren't on those. His eyes are on where the pain is, as is anybody's,
Yeah.
So yeah.
Yeah. And
So
so, I mean, he's
complete lack of
basically,
dorsiflexion.
yeah,
Mm-hmm.
he's resting in plantar flexion, basically. And, and so I said to him, look, I ended up going, I mean, does he have an articular impairment? No, it's generally muscular, but you can have, we call them vectors or muscles that are gripping and causing a joint to become quote unquote not moving well, right? You could also have lack of neural mobility or a connection between the foot and the hip that's causing the foot or the hip to not move optimally. So an assessment standpoint, I assessed him in sitting, I assessed him in supine. I'm not going to go into the intricacies of the assessment because this is really about the movement program with him. But I ended up, doing your sort of all of your talar tilt tests, all of your sort of special tests with a foot. I looked at the subtalar joint. I had him in prone. I had his foot off the table, like right where the talocrural joint is. I had that hit the back of the table. And I assessed the talonavicular joint. I assessed the calcaneal cuboid joint. I did all of that. And just from a positional finding, he, even in standing, he had this sort of externally rotated midfoot, a lot of gripping, and then a vic and the cuboid, just that is his thing. A significant tightness in the gastrocs and the bottom of the foot. Not unusual, right? For anybody who walks, like we do here in New York. So significant tightness. So then I went into the hip. I said, can you just lie on your back? I assessed the range of motion. Passively, he was limited to about 95 in the right hip. Okay. And I thought maybe that was just muscle guarding because he's pretty super flexible. He's one of the hypermobile types. I had him do a straight leg raise. Fine. I had him, I did do like a couple special tests, like the sort of labral hip, flexion, internal rotation, adduction. Nothing really flared him up at all. I didn't think he had anything sort of sinister in the right hip. So what I ended up doing is I gave him a little bit of cueing, some mental imagery, because I wanted to see if I could, because he actively can move his hip.
Mm-hmm.
Pretty normal. When I passively do it, I'm getting a block and I'm like, huh.
Yeah.
And that's me probably moving it and putting it in a better position. Unknowingly, I just do what I do. He just compensates with whatever. So I ended up, I said, look, I want you to imagine. So I held his foot and I didn't want to like assist the hip up. So I held his foot and I said, can you just imagine your big toe growing long? Imagine your pinky toe growing long. Imagine you've got a beautiful fan under your foot and you have a lot of softening in the foot. And he actively brought his leg up into a bent knee raise. And it was worse.
Mm-hmm.
It was worse. So I was like, oh shit, what do I do now? It's consistent with what I found. He did. He mentally sort of corrected, modified, made his foot put his foot in a different quote unquote position. Did something to the nervous system down there, maybe peripheral nerve, and then he brought his knee to his chest, and he was worse. And I was like, okay, well, this is all matching. It's matching up. So what I did was I did the same thing. I put my hand literally underneath him in supine. I did a little bit. I just pulled the sit bone back, and I said, "Can you just bring your same imagery? Bring your knee to your chest." Oh, that's much easier. Okay, and so I straightened his leg out, and I just put my hand on the femur. And I just did a little bit of a posterior glide. And Susan, I looked at the foot and the foot was like doing this. It was inverting. So it was making it worse. So I normally wouldn't do that to that extent. But when I see areas of the body that are making each other worse like that, I try to like confirm it in an open chain position. And it was making each other. But this guy is not an easy person to treat. It's part of our podcast, right? These are tough patients. But I want you guys to be aware of, okay, well, why are they making each other worse? Is there a direct connection between them? Yes, there is. Is there a neural connection? Yes, there is. Or does he have a sensitive nervous system? He could. Is it an overall dural issue? Those were all on my radar as potential drivers,
and there's reason to think about that because of the neck and the thorax as well. So but it's interesting. I just want to point this out because open chain, closed chain. I'm doing hands and knees with lumbar, extension, anterior rotation of the pelvis, posterior rotation of the pelvis, lumbar flexion. All of those made him better, but his knees are bent and his feet are not in play. So what I would find interesting is looking at hands and knees and putting his, getting him on his, making, like, are his feet like laying flat in plantar flexion, or is he up on his toes? And
Yep.
see if it makes it worse or better. But the interesting thing is when you don't mess with the foot and you bring the pelvis and that again, you rotate the pelvis over, or you do a posterior glide of the femur, which puts the femur nestled back into the acetabulum again, and then he's able to move better. Mm-hmm. So, but the foot was doing all kinds of interesting things in open chain as he moved his hip better. So
yes, exactly. So I will just give you a little bit about what I did, and then we'll end, and then in this part two, I'll talk about a little bit more exercise. I did get him into all fours. Got him onto all fours. I said, dorsiflex your foot. Well, needless to say, that did not go down well, right? So I said, just dorsiflex your feet. The hip was moving. So I said, okay, this is closed chain, mimics the wall. So I actually did give him. So this is what I did the first session. I had him in the all fours. I said, just relax your feet. Don't flex your feet. Like, he knew the term dorsiflex. So don't dorsiflex your feet. Relax your feet. Close your eyes. Get yourself into what you think is your center. Okay. I had him put like a TheraBand. A guy centered him, and I had him put a TheraBand on the table. I said, this is your center. Okay. Do it with your eyes closed, because somebody like him, I didn't want the eyes in play, just because I think his system would have been all over the place. I don't know why I did that, but I did. So I said, center yourself, and I want you to go back on your heels and get neutral. I said, we're not going to go into sort of camel, just I taught him how to do neutral, and then go forward. So not straightening his knee out, but he's getting a little bit of lengthening of the right side. So moving forward on his hands. He was fine with that. His neck and shoulder, thorax were fine. Then coming back into more like a child's pose. So he did that. That was one home program I did for him. Then I gave him what we call, I just gave him lying on his back in a comfortable position. And then I gave him, honestly, just basic heel slides. And that was very easy for him to do. So I ended up having him going into sitting. So I'm just demonstrating here, sitting, shoes off, and with his right leg. So I had him look down at his foot, imagine the big toe grow long, the pinky toe grow long, and I just had him his foot like on a towel or something slippery that you could slide. And I had him go into knee extension with the foot imagery. So what I ended up having him do when he sat down, Susan, is I had him take his hand, grab his sit bone, and pull it back, just like I did in standing. So that gave him a more optimal position for him in sitting. So the hip was modified, corrected. I had him put his feet on the ground on a slippery washcloth, and imagine his big toe grow long, his pinky toe grow long, everything softening. And I had him do a heel slide. So when he went into that knee extension, it sort of put him into that plantar flexion. Then when he came back into dorsiflexion, knee bent, I had him do more of that imagery. So that's what I gave him for a home program. All fours. The heel slides were easy. So I said, you can skip, he can do those, but those were easy. And then I just gave him the seated heel slides with the hip modified. Because if I didn't, he would have gone. We checked him out. I said, don't do anything to your hip, just do your heel slide. And it was like all over the place. So I had him, modify the hip with a sit bone, but lifted the sit bone up and closed his eyes, imagery with the foot. And then I had him go into heel slides, knee extension, knee flexion. So that was his first treatment. It was a long session, as you can imagine. You have your thoughts on that at all?
No, I just, it's going to be interesting to see what he came back with.
Yes.
After doing some different kinds of very simple exercises, but exercises that didn't aggravate each other, but, kind of help begin to join one up with the other to see what reveals itself in episode 2. Yeah,
episode 2. So just, ending here, just think about what we discussed so far. think about why, if you have patients that are coming back, if you treat, let's say you treat an area of their body and they feel, oh my God, that was great, but my neck is feeling weird. You made something worse, right? Or something in the nervous system didn't like it. So just think about that. We can discuss that on the next episode. Enjoy, guys. Thank you.
Right. See you on episode 110.
Episode 110.